Good evening, students. Welcome to you from Sri Rama Hospital, Jagaipet. We are studying about the topic of the shock. In the previous two classes, we learned about hemorrhagic shock, and today let us learn about the septic shock. These are the two types of shock which are important as regard to surgical sciences. The other types of shock are relevant in medicine. I hope you are studying those topics also for better understanding of the shock in a wholesome manner. So the septic shock is one of the things which is not completely understood. The pathophysiology is not completely understood because it carries a very high mortality rate. And it is resistant for treatment in many of the cases. So why it is so? So it is not clearly known. So, but whatever it is that is understood so far, that I will try to explain it to you. Of course, you can read in your textbooks of surgery as well as medicine about the septic shock for a better understanding later. If you know the basic principles, then it will be easy for you to follow the remaining topic. There are many synonyms. Bacteremic shock. So that was a very, very old term that is not being used at all now. Sepsis syndrome. Then septicemic shock. So these are the other names given for this particular thing. And earlier there was one more word that was called the massive sepsis. But now all these things are being deleted. Now only sepsis syndrome or septic shock are the two commonly used words to denote this particular condition. What is septic shock? Septic shock is defined as a life-threatening organ dysfunction due to dysregulated host response to infection. So it is normally there is host response to infection, but here there is some dysregulated host response. So how it occurs, how this dysregulation happens is not well understood. So it is a life-threatening organ dysfunction due to dysregulated host response to infection. Etiology: microbes responsible for sepsemia. Bacteria is the common cause. Gram-negative aerobes. These are the commonest microbes which are responsible for causing the septic infections. Septic shock, like E. coli, Pseudomonas, Klebsiella, Proteus. Then protozoal infections, falciparum, malaria. Of course, in this season, we will see a good number of cases of this falciparum malaria going into the septic shock. Then virus infections like dengue fever, and recently we are seeing or we are threatened with the dreaded coronavirus, that is COVID-19 infection. So this also is one of the things which causes this dysregulated host response, causing organ dysfunction and death of the patient. Then fungal infections. Source of septicemic infection causing shock. Gram-negative organisms commonly cause infections in the relation to the alimentary tract, biliary tract, urinary tract. So these are the three tracts that are commonly being infected. So that is why any infection originating in these three tracts must be dealt with at the earliest time. Otherwise, it can lead to this sepsis syndrome. Even simple enterocolitis can also cause this sepsis syndrome. The predisposing factors, extreme surface, immune deficient states like HIV, diabetes mellitus, advanced malignancy, jaundice, splenism, drugs like antimetabolites and corticosteroids. So patients who are under antimetabolites and corticosteroid treatment, they are also susceptible or predisposed for the septic shock. Pathophysiology septicemia. Yesterday we discussed about septicemia. So presence of proliferating microbes in the bloodstream is called septicemia. So whenever there is proliferating microbes in the blood, will it cause shock? Will it cause septic shock? No. Let us see how it causes. Septicemia, whenever it is there, so whenever the bacteria are circulating in the blood, there will be activation of inflammatory systems in the body. That is activated leukocytes, release of interleukin and TNF from macrophages. These are the inflammatory mediators. So the activated leukocytes and these inflammatory mediators, what they cause? They cause the inflammatory process. So inflammation, is it good for the person or bad for the person? If some organism is entering our body is responding by producing inflammation. Is it good or bad? It is good. Okay, anything exaggerated is bad. Any exaggerated is bad. So it should be the optimum level. So at the optimum response is always beneficial. So these inflammatory mediators, they cause the inflammatory response. So with this inflammatory response, the bacteria will be attacked by these leukocytes and these inflammatory mediators, and that cause control of infection, and it is beneficial to the host. If it occurs in excess, so if this inflammatory response is in excess, it causes systemic inflammation response syndrome. That is called SIRS, which produces multiple organ dysfunction syndrome with multiple organ system failure. So multiple organs and multiple systems, they will fail. So first there will be dysfunction, later there will be failure. So this is the sequence. So why it occurs in excess, that we do not know. So if any factor that triggers this response, that can cause this SIRS, MODS and MOSF. We have seen certain predisposing factors and certain infections like the gram-negative infections. They are more prone to get this septic shock. So whenever there is systemic inflammatory response syndrome, that means there is generalized inflammation. We have seen inflammation means it is nothing but vasodilatation, fluid exudation, and cellular migration. So cellular migration means what cells they migrate out? What cells migrate during inflammation? In acute inflammation, what cells migrate out of the systemic, of the capillary circulation? The neutrophils. Macrophages, no. Are the macrophages are there in the blood? Are there macrophages in the blood? No. Then how can they come out? Actually, the basophils, they come out. The basophils, once they come out, they transform themselves into tissue macrophages. Okay, the neutrophils, once they come out, they will do the function. Afterwards, will they return to the circulation or will they stay back there, or what will happen? What will happen to the neutrophils which have leaked out of the capillaries? Once their function is subserved, then what will they do? Will they return to the circulation? So they once they come out, that means they have to do their duty. That means do or die. So their function is to attack the microbes. So how they attack the microbes? By engulfing. Number two, by bursting. Once they burst, they will release a lot of lysozymes and inflammatory mediators. Some of them are direct inflammatory mediators, some of them substances, they stimulate the inflammatory mediators in the tissues. So they activate the inflammatory process. So the lysozymes, not only they secrete enzymes which will cause proteolysis and digestion of foreign protein particles in the tissues, as well as they cause the accelerated inflammatory response. Now it is thought to be the main structure or main cell that is found to be responsible for even the SIDS. These activated white cells, when they travel in the systemic circulation, they will go and adhere to the target organs. And there they liberate the lysozymes and inflammatory mediators and provoke the inflammatory process. That is how the systemic inflammation spreads through the activated leukocytes. Okay. So whenever there is systemic inflammatory response, there is vasodilatation, fluid exudation, and cellular migration. The cellular migration will help for phagocytosis as well as lysosomal activity and promotion of the inflammation again by the leak out white cells. So if there is generalized capillary dilatation, so systemic inflammation means there is generalized inflammatory response. So with generalized inflammatory response, there will be leakage of fluid and that leads to decreased circulatory volume. So whenever there is decreased circulatory volume, the baroreceptors and ACTH is stimulated. We have seen in the hypovolemic shock, whenever there is hypovolemia, there will be stimulation of these two. So this causes the increased cardiac output. So because of the inflammation, there is peripheral vasodilatation. So with peripheral vasodilatation and increased cardiac output, the extremities will be warm and they are pink. In hypovolemic shock, what we have seen, it is a cold shock. Peripheries are extremely cold. They are moist or they are sweating and they are paler. But here they are pink, they are warm, and patient is in shock. So this is warm shock. Late stages. So if it is not responding, it is progressing, then there will be MDF and TNF and lactic acidosis and other unknown mechanisms. They cause myocardial depression. This myocardial depression leads to decreased cardiac output. There is continued capillary leak, severe third space loss, decreased cardiac output, and increased levels of catecholamines. Because whenever there is decreased cardiac output, there will be increased levels of catecholamines. So this causes the cardiac elements will cause peripheral vasoconstriction. So this causes cold shock. So there are two phases in septic shock: warm shock and cold shock. Warm shock is due to the hyperactivity of the cardiac muscle along with vasodilatation. That means there is increased cardiac output with vasodilatation. But late stages, what will happen? There will be vasoconstriction with decreased cardiac output. And end stage, there will be pulmonary vasoconstriction and bronchospasm. So in hypovolemia, we have seen that the vital organs are spared till the last, but in decompensated stage, they also are involved. Similarly, here also you can see in the late stages, even the pulmonary vessels will be subjected to vasoconstriction and there will be bronchospasm due to PGI2 and leukotrienes. So there will be many inflammatory mediators as well as the toxins secreted by the microbes. So these toxins, they stimulate various types of inflammatory mediators in addition to causing destruction to various tissues. So it is not only the assault produced by the bacteria due to their toxins, but also the inflammatory mediators which are secreted in excess, because there are so many bacterial toxins are being released. So the body responds to that and it responds by producing more of these mediators. So both these things are causing damage in their own perspective. So this can lead to the bronchospasm and pulmonary vasoconstriction, lead to the ARDS. So whenever there is ARDS, there will be hypoxia, and in addition, if there is cold shock, the organ dysfunction syndrome will ensue. Summary: septicemia, there is increased third space loss because of peripheral capillary dilatation, generalized vasodilatation. There is decreased cardiac output, and there is hypoxia in the later stages. So because of these three, there is multiple organ dysfunction syndrome. Okay, Santi, you have some doubt? The ACTH and cortisol, can't they cause the peripheral vasoconstriction? The vasoconstriction caused by cortisol is too little. The main thing that causes vasoconstriction is sympathomimetic amines. The role of cortisol is sensitization of the adrenergic receptors in the blood vessels to the circulating adrenaline and noradrenaline hormones. So when they are not being stimulated in high quantity, the simple cortisol do not cause vasoconstriction. Cortisol per se has no action on the blood vessels. Whatever action it has on the heart is because of the fluid retention and sodium retention and altered glucose metabolism. That's all. Clinical features of septicemic shock. So here we are seeing two things. One is septicemia, the other is the shock. So there will be high fever with chills and rigor. Sometimes there will be hypothermia. Tachycardia, sweatings, vomiting. Then there are features of shock. Early stage is warm shock. There is pink, warm extremity. bounding and rapid pulse. Why there is bounding and rapid pulse? Of course, rapid pulse we know hyperpyrexia can cause. Then increased cardiac output also can cause the rapid pulse. Then why it is bounding? CO means carbon monoxide. I cannot understand. CO. What is increased CO? Okay. Increased cardiac output. Okay, increased cardiac output. What is bounding pulse? What do you understand by pulse is bounding? Its volume is very high. Its volume will be high for two reasons. Pulse volume can be high for two reasons. What is pulse volume? It is the difference between the systolic and diastolic blood pressure. It is volume. That is the volume. So, systolic blood pressure means it is dependent upon cardiac output. Diastolic blood pressure means it is dependent upon the vascular resistance. If the pulse volume is increased, means there may be two things. Number one, systolic blood pressure might have increased, or diastolic pressure have decreased. In warm shock, what is happening? Because of vasodilatation, there is reduced vascular resistance. So the diastolic tension is fallen. Systolic is increased because of increased cardiac output. That is why the pulse volume increases tremendously. So it is a bounding pulse. Blood pressure maintained or low, there will be tachypnea. The tachypnea is mainly for two reasons. Number one, due to hyperpyrexia. Number two, due to hypoxia of shock. In cold shock, there are cold, pale extremities. Patient is drowsy, tachycardia, falling blood pressure, cyanosis, and tachypnea. So, the clinical presentation is a mixed presentation. The patient will be having high fever. In addition, whenever there are hemodynamic changes, then that means the patient is developing shock. And these will be associated usually with some organ dysfunctions. The organ dysfunctions already we have seen in the hypovolemic shock. What are the dysfunction? That means there can be organ dysfunction of the kidney. So when the organ dysfunction of kidney will be there, what will happen? There will be oliguria. There may be organ dysfunction of the liver. It can produce jaundice, elevated enzyme levels. Organ dysfunction of the lungs. It produces hypoxia and tachypnea and reduced PaO2, increased PaCO2 in the blood. Then organ dysfunction of the brain produces delirium, restlessness, later coma. Alimentary tract produces the stress ulcerations. The blood can produce disseminated intravascular coagulation. So in the recent corona deaths, we are seeing all these complications. These are nothing but they are the features of SIDS and MOTS. So the SIDS and MOTS manifest at the terminal events in most of these septic shocks. What investigations we do? We have do many number of investigations. For sepsemia, total leukocyte count, it will be usually more than 20,000 per cubic millimeter. Sometimes there will be leukopenia with less than 4,000 per cubic millimeter. Especially you see this with salmonella infections. Blood cultures will help us. Then for circulatory failure, CVP, PaWP, oxygen saturation, ABC. So they must be regularly monitored. during the whole course of treatment. For ARDS, PaO2, PaCO2, and chest X-ray. So we have studied all those things in the hypovolemic shock, the complications of hypovolemic shock. We studied about those things. Then for renal function, blood urea, serum creatinine. For hepatic function, serum bilirubin and enzymes. For hematological abnormalities, PCV, bleeding clotting time, platelet count, fibrinogen estimation. Because I already told you, the hematological dysfunction is DIC, disseminated intravascular coagulation. So in disseminated intravascular coagulation, there will be platelet consumption, so producing thrombocytopenia, and there will be fibrinogen consumption, causing fibrinogen reduction, and bleeding time and clotting time are prolonged. Principles of management. The main principle is early recognition. So once the infection to the bloodstream, so whatever may be the infection, in gram-negative infections and those viral infections, there is dengue fever and then the corona infection or COVID infection, then falciparum malarial infections, you must be very cautious. So once the patient is developing generalized infection means, so you must recognize and treat it appropriately with the antibiotics. So early and adequate antibiotic therapy has to be given. Control of source of infection by surgery or by antibiotics. So if it is feasible, you have to control the source of infection. For example, if the patient is having an obstructed bile duct due to a stone in the bile duct. So how do you manage stone in the bile duct? A stone from the gallbladder has passed down into the bile duct and it is impacted. So whenever there is sudden obstruction to the bile duct, first how it manifests? Whenever there is sudden obstruction of the bile duct, clinically how it manifests? Okay, it is colicky pain. There is partial obstruction, it produces colicky pain. If the duct is completely blocked suddenly, so there is sudden accumulation of bile in the proximal biliary tract. Okay, that produces jaundice, as well as that also produces infection. So the bile duct is infected, what do you call it? And what is the clinical manifestation? Cholangitis. Very good. What is the clinical manifestation of cholangitis? There is a triad. What is the triad? Tell me. A triad is there. No, it is wrong. Murphy is wrong. Tell me what is the name of the triad and what are the triad contains. That is right. Pain, fever, jaundice. That is right. But what is the triad name? What is the name of the triad? That is right. Pain, fever, jaundice. That is okay. Ah, very good. ABC, you are right. It is called Charcot's triad. Wonderful. Okay. So a patient has come to you with Charcot's triad. So immediately the patient is in. So this patient with Charcot's triad can go into septicemic shock. So once you identify the infection, once you identify the source of infection, where the source is in the bile duct, a stone is blocking it. You must control it by surgery or by antibiotics. So anyway, you give the antibiotics, but an obstructed bile duct should be relieved of obstruction. If obstruction is not relieved, the sepsis won't be controlled. So please remember that. Anywhere in the body, if there is infection due to obstruction of the duct or passage, the obstruction should be relieved. Relieved, that's all. I didn't say removed. It should be relieved. So immediately what you do, tell me, to relieve the obstruction. Bile duct stone impacted. What do you do? How do you manage acute cholangitis with bile duct obstruction due to stone? Okay, if you are a endoscopist, if endoscopy facilities are available, what do you do? So immediate thing what you should do is you have to do the ERCP, that's fine, and you have to relieve the obstruction by passing a stent. You don't put more time in relieving the or removing the stone because it got impacted. Removal of the impacted stone is very difficult because it will be large in size. It won't come easily. Sometimes you have to use various maneuvers like basketing or balloon extraction or ultrasonic lithotripsy. All these things you have to use. So you don't meddle the duct too much because it is inflamed. It is very much edematous. It is congested. There is sometimes pus also will be there in the bile duct. So such tubes you don't meddle much. Your intention will be only to drain, drain, and drain. So how to drain? You put a stent. So first you put a stent or nasobiliary tube and drain the bile duct. So the source will be now controlled. Of course, you have to give adequate antibiotic therapy. It should be adequate. Just like one or not two shots, you must give the required dose intravenously. It should be maintained. The dose must be maintained till the patient completely is recovered from the infection. And if necessary, you have to do the culture sensitivity tests also. Early hemodynamic resuscitation and continued support. So once you see any patient with alimentary tract infections or the bile duct infections or urinary tract infections where there is gram-negative infection, or if it is a virus infection like dengue fever or the COVID infection. So you must prepare gear yourself for hemodynamic resuscitation. So there should be continuous monitoring of the patient. So probably nowadays you are seeing in the WhatsApp also, people are advising everyone to check pulse oximeter. So to buy a pulse oximeter, keep it in your house and check morning and evening the pulse oxygen saturation in the blood. If it is less than 95%, immediately report to the doctor. That's what we are getting the messages. Why? That is for early hemodynamic disturbance recognition. So whenever the pulse oxygen saturation is falling, pulse rate is rising, or patient is getting tachypnea or hypoxia, that means that there is hemodynamic disturbance. So immediately you must respond and you must resuscitate. And of course, you must give continued support. Then you have to give proper ventilator management. So whether patient needs simple oxygenation or patient needs a positive pressure ventilation, so you have to decide. Of course, this will become a teamwork. So once one fellow will not or cannot manage. So a surgeon, an intensivist, an anesthetist. So all these people should come together and manage these cases. So management of sepsemia and management of shock, management of MOTS. We have seen whenever there is sepsemia, it can produce increased heart space loss, decreased cardiac output, hypoxia of the. This can lead to MOTS. So sepsemia you have to control by antibiotics and surgical intervention. Increased third space loss because the fluid is leaking. If you give simple crystalloids, it also will leak. That's why you give colloids. But this also has a danger because if there is peripheral vasodilation is too much, even colloids also will leak. If the colloids leak into the tissues, that will be more harmful because once they go into the tissues, they draw more water and they become more edematous. So colloid infusion, then decrease cardiac output, you have to stimulate the heart with the help of inotropes. But in case of hypovolemic shock, we choose the inotropes to the last. We try to stimulate the heart by replacing the lost volume. So if there is hypovolemia, you correct the hypovolemia, then automatically the cardiac function will be restored. But here, in the early stage itself, you go for the inotrope injections to maintain the cardiac output. Then hypoxia is managed by the ventilator support. So if there are any renal, hepatic, hematological systems dysfunction is there, so you manage them as per their trouble or as per their dysfunction. So management of sepsemia, surgical drainage of septic focus. Example, stenting of CVD in impacted cannulas with cholangitis. Ureteric stent in stone causing obstructive pyelonephritis. If an abscess is there, you have to drain it. If gangrenous area is there, you have to excise the gangrenous area along with drainage. If any infected organ like appendicitis is there, you have to remove that organ. So that is appendectomy operation and drainage of the pus has to be done. Then you have to give broad spectrum bactericidal antibiotics like cephalosporins, third generation cephalosporins, aminoglycosides, 8-aminophenols, flucloxacillin, along with metronidazole. So because most of them are the gram-negative organisms, you have to give these particular antibiotics. Of course, this is an experimental study to reduce the bacterial membrane debris in the circulation, specific gamma globulins to bind endotoxin, polymyxin E, activated protein C. Then management of shock. Volume replacement is done with crystalloids or colloids guided by CVP or PAWP. So there must be CVP catheter must be there. You must be continuously checking. But in hypovolemia, we know. For example, you estimate the loss as 1 liter of fluid. You give 1 liter of fluid administration. So the blood pressure will be coming up, pulse rate will be falling down, and your output will be there. So by this monitoring, you will be able to say whether the fluid or blood what you are administering is adequate or not. But here there is no loss. There is no loss of fluid. The simple vasodilatation and myocardial depression. These two things are causing the shock. So the fluid is leaking. So you maintain the volume in the blood. So again, there is a problem of still more leakage. But whatever is, you have to maintain the volume. So how much volume you have to give to maintain the volume? That can be gauged only by doing a central venous pressure monitoring. So continuous CVP monitoring, and on that you administer crystalloids. Because if you give more of crystalloids, they will cause pulmonary edema. and all the tissues in the body will be logged with fluid. Give vasoactive drugs indicated if cardiac output is not maintained even after volume replacement. Dopamine, dobutamine are chosen. Then ventilator support, either plain supply of oxygen through a mask or through the nasal catheters or with the help of a ventilator. Monitoring of vital data, CVP, PAWP, and ABG. This is important. Then organ dysfunction, the oliguria management. I am not explaining the oliguria management here. Already I have discussed in yesterday's class how you manage oliguria management in case of shock. First, you correct the hypovolemia by looking at the CVP, by monitoring the CVP. If it is not responding, give dopamine. If it is not responding, then you think that it is a case of renal failure and manage it with dialysis. For stress ulcers, you H2 blockers or omeprazole. DAC management. DAC is managed by disseminated intravascular coagulation. It is managed by heparin and fresh frozen plasma transfusion and platelet transfusion. Then systemic inflammatory response. It is managed by steroids, increasing gut perfusion, because translocation of bacteria from the gut also is responsible for aggravating SIDS. Then free oxygen radical scavengers. So if those scavengers also will be given. Prognosis. Prognosis is bad in the following situations: aged persons, unresponsive, low cardiac output shock, ARDS, DAC, leukopenia. So these are the conditions where you will see high mortality rate. So this is about the septic shock. Any doubts in the septic shock? Okay, if you have no more doubts, I will go to the next this topic, that is multiple system organ failure. Causes of multiple system organ failure: sepsemia, just now I have seen. Then shock, there is hypovolemic shock, delayed or inadequately resuscitated. Acute hypoxia due to any condition. The examples of acute hypoxia being airway obstruction, pulmonary embolism, pneumothorax, acute pulmonary edema. So these things will cause acute hypoxia. Then massive tissue injury like polytrauma, burns, massive blood transfusions can also cause. Then poisons like snake venom, acute pancreatitis, disseminated malignancy. We have seen just now the septic shock. The septic shock is that syndrome or sepsis syndrome or SIDS syndrome is seen not only due to sepsemia and infections. They can also follow the acute pancreatitis. They can also follow multiple trauma. with massive injury, polytrauma with massive injuries. There also there can be systemic inflammatory response. The organs at risk: lungs, they cause ARDS, acute respiratory distress syndrome. Circulation, there will be high or low output failure. Kidneys, there will be acute oliguria or non-oliguric renal failure where creatinine levels are rise above 2 milligrams per cent. Then GIT, stress ulcers, paralytic ileus, gastric dilatation. So these are the things that will happen to the organs whenever they are failing or they have failed. Liver, hepatocellular dysfunction, evidenced by elevated SGOT, twice normal bilirubin more than 2 milligrams per cent. Central nervous system, there will be confusion, lack of intellect, and then coma, then coagulation failure as DIC or clotting factor deficiency due to hepatic dysfunction, then metabolic failure as glucose intolerance, autocatabolism of proteins. So these are the systems and organs dysfunctional status. So whenever they are dysfunctional, this is how they manifest. Management, prevention, proper and timely attention of ABCD. So whenever a seriously ill patient comes to the hospital, we have to attend to these things. That means to the airway, to the breathing, to the circulatory system, and of course the drugs disposition and diagnosis. So airway, attention to pneumothorax and hemorrhage in a polytrauma and critically patients. Prevention of sepsis in a critically sick patient. Treatment, treat the underlying cause. Interrupt the pathogenic pathways with steroids, aspirin, NSAID, heparin, H2 receptor antagonists, and specific treatment of failed organs. Prognosis, failure of 2 or more than 2 organs carry a mortality of 70%. If renal system is one of the 3 failed organs, the mortality will be around 98%. So ARDS and renal failure, if these 2 are present means then patient's prognosis will be very, very, very bad. So this is about the organ failure. Now we will go to a topic that is blood transfusion. In hypovolemia due to hemorrhage, we have to give blood transfusion. Apart from that, there are many other indications for blood transfusion. So you should know something about blood transfusion. So if you want me to tell about this, I will tell you about this blood transfusion now. If you think that you can read it at home, then I will leave this topic. This is one of the frequently asked theory question, essay question in the theory examination about blood transfusion. We see many number of questions on this. Very frequently this is being given. That is why I want to tell you about this. Shall I continue? Okay. The first recorded blood transfusion was given by James Blundell. The indications for blood transfusion: hemorrhage. In major acute hemorrhage, after initial resuscitation with crystalloids or colloids, you have to give blood transfusion. So pending blood transfusion, we give crystalloids. Then we give blood. So in any patient who has lost more than 750 ml of blood. A hemoglobin of 7 grams per cent is adequate to deliver oxygen to the tissue if circulating volume is normal. Then the other indication for blood transfusion is for chronic anemia. Unresponsive to considered treatment. In this case, because in chronic anemia, the hemoglobin in the RBC is less. So that is why what you do is you go for the packed cell transfusion. If you give the whole blood transfusion, you are unnecessarily giving more of plasma. So the needed thing, that is the blood cells. So you transfuse only that is called the packed cell transfusion. In certain bleeding disorders, periodically the person suffering from this bleeding disorder has to be administered this blood products. So fresh blood transfusion containing all coagulation factors is useful, and isolated blood products are better in some of these congenital hemorrhagic diseases. Precautions before giving transfusion. Once you enter into the house agency, you will be regularly administering blood transfusion to the patients. So some precautions you have to take before giving transfusion. Number one is compatibility tests by grouping and cross-matching. All of you are well aware of the various groups and method of cross-matching. So you have to do the cross-matching donor's RBC with recipient's serum. Check for patients who are prone for cardiac overload. So who are the patients prone for cardiac overload? What is this cardiac overload? That means whenever you administer blood, you are increasing the blood volume. For a simple crystallized solution, it passes through the capillaries into the extracellular fluid. The extracellular fluid, if it gets diluted, then automatically the kidneys will excrete out under the influence of various hormones. So if it is a simple crystallized, means there is nothing to worry. Within another half an hour, that gets controlled. But if you are giving pure blood, because you are giving the plasma and RBC, which cannot pass out through the capillaries, they stay back in the capillary, in the blood circulation system. So if any patient is having already some pre-existing diseases in the heart or hemodynamic system, even small quantity of blood transfusion will cause the more preload on the heart. So excess preload on the heart will lead to congestion in the systemic circulation. If it is on the left side, it produces pulmonary congestion. So who are they? Old age. So old people, because the hearts have become weak, so suddenly if the cardiac blood volume increases, they will not be able to cope up with that blood volume. And for that reason, you cannot withhold blood for them, because they also cannot tolerate acute blood loss for longer periods, and hence the decision to start transfusion is made early in these old persons. Then in chronic anemia, because of pre-existing hyperdynamic circulatory states, if you give the whole blood, that will add to the hyperdynamic states of the heart and will aggravate congestive failure. If there are any coexisting cardiovascular and pulmonary diseases. So you have to inquire before giving blood transfusion whether the patient has any of these three problems. If these three are there, then still you can give blood transfusion, but there are certain methods you have to follow for giving blood transfusion in these patients. So in these patients, what precautions you have to take to give transfusion slowly? To monitor frequently for evidence of cardiac overload by CVP measurements and by examining rails at the base of the lungs. rails at the base of the lungs, they indicate pulmonary congestion. So whenever pulmonary congestion is occurring in a patient who is taking blood, means his left heart is going to fail. There is going to be left cardiac failure. So what you must do is you must stop the blood transfusion. So there are precautions you have to take in those three groups of patients. Then what are things you will transfuse? You transfuse whole blood. If needed, you transfuse only packed cells. Packed cells means you transfuse only RBC. Then you transfuse only fresh frozen plasma. So you give only plasma only, though without any packed cells. That's why what you do is, whenever you want to have the packed cells, you take the packed cells and leave behind the plasma in the bag, and that is stored again. That is frozen. So this frozen plasma can be used for some coagulation defects. Then from the whole blood, you can isolate certain particles or parts of the blood separately. That is number one, platelet. You can take out the platelets separately and give the transfusion. So this is called the platelet concentrate. Cryoprecipitate, albumin, specific coagulation factors. So these are all the products of the blood which can be given for transfusion. Let us study each of them. Whole blood, it is collected in bags containing anticoagulant solution. So whenever you want to give blood transfusion, you ask the donor to come. From the donor, you draw the blood. So you collect the blood in a bag. That bag contains the CPD solution, citrate phosphate dextrose solution, and it is stored at 4 degrees centigrade. Normally about 400 ml of blood is run into the bag, which already contains 75 ml of the anticoagulant solution. So this anticoagulant solution is there in the bag already. So into that bag you draw the blood. While you are drawing the blood, now and then you mix the blood bag. Probably you must have donated blood some time ago, and you must have seen all this. The shelf life of this blood is 42 days, but is used within 21 days. So once you draw the blood, you must write down the group of the donor, then date of drawing the blood, because you have to use it within 21 days. The platelets and labile clotting factors, that means factor 8 and 5, are quickly depleted on storage. Hence, in bleeding disorders, ultra fresh, less than 3 days old blood is transfused. So if you give a blood of more than 3 days duration, so it will be lacking platelets as well as the clotting factors like 8 and 5. 1 unit of blood transfusion raises the hemoglobin by 7 grams percent. Sorry, not by 7 grams percent, by 7%. So roughly it will be 1 gram percent. So normal value is about 14 to 16 grams per 100 ml. So if you give 1 unit of blood, then the hemoglobin percentage will rise by 1 gram. Then about packed cells, they are useful in treating chronic anemia in old people, and also packed cells are given in patients with cardiovascular disability. So once you separate the packed cells, the remaining thing is the plasma. So that plasma will be stored. So if it is fresh, we call it as fresh frozen plasma. That means the plasma is separated from the blood and is frozen, and it is immediately used afterwards. Within 3 days it is used. It contains all clotting factors except platelets, and hence is useful in bleeding disorders, especially common in overdoses and in liver diseases. So this is called FFP. It doesn't need cross-matching. Platelet concentrate indications thrombocytopenia. So in the dengue fever season, we will be seeing many number of the patients are receiving these platelets. So this platelet is nothing but platelet concentrate. So indication is thrombocytopenia, where the platelet count is less than 50,000 per cubic millimeter. A platelet count of less than 70,000 per cubic millimeter provide adequate hemostasis if the platelets are normal. So the normal count of platelets is about 1.5 to 2.5 lakhs per cubic millimeter. So you do not transfuse till the platelet count comes to 50,000. But in this dengue fever season, many of our physicians got a lot of experience with these platelet transfusions and platelets. So they transfuse only when the platelets has fallen less than 20,000 per cubic millimeter. So once the patient's platelets have fallen to 70,000, they will keep the patient under observation and monitor the platelets regularly morning and evening. If they fall below 20 or 15,000, then they will give platelet transfusion. 1 unit of platelet concentrate raises the platelet count by 5,000 to 10,000 per cubic millimeter. In dengue fever, there is not only thrombocytopenia, there is also systemic inflammatory response syndrome with multiple organ failures. Then cryoprecipitate. It contains factors 5, 9, and fibrinogen. So it is a fractionated part of the blood. So in certain bleeding disorders where there is deficiency of these factors, you can use this particular thing. This is called cryoprecipitate. It is used in hypofibrinogenemia, hemophilia, von Willebrand disease, and uremic coagulopathy. Large quantities of factor 8 can be administered with small quantities of cryoprecipitate. Then specific coagulation factors. Specific factors like factor 7, factor 8, factor 9, and factor 10 are also isolated. So you can give these specific coagulation factors from the blood. So in congenital bleeding disorders, the patients require these regularly. So they are useful in specific factor deficiency states. Then albumin, it is used in burns, nephrotic syndrome, cirrhosis of liver. Its use in hypovolemic shock as a volume replacement should be weighed against its cost, because it works out to be very costly to give this albumin. That's why it is not being employed in managing the hypovolemic shock. SCAG mannitol blood, indication in chronic anemia. A proportion of blood plasma is removed and replaced with 100 ml of crystallized solution containing sodium chloride, adenine, glucose anhydrous, and mannitol. This is divide of plasma protein. So these are all the types of blood products. Then types of transfusion. Homologous transfusion. Transfusion from a voluntary, healthy, and safe donor after counseling for any evidence of communicable diseases and after screening for HIV, HBsAg, HCV, malarial parasite, and doing cross-matching. So these precautions you must take before taking the blood from the donor. So once the donor comes, you must assess his healthiness. That means whether his hemoglobin percentage is normal or not, whether his hemodynamic system is normal or not. Under these two conditions only, blood should be taken from him. And it should be a voluntary donor, not a forced donor or not a bribed donor. And he must be proved to be safe. Safe means he must be not having any of the communicable diseases through the serum. So what are the communicable diseases that passes through the serum? HIV, HBsAg, HCV, malarial parasite. So these things should be excluded. So you have to test for those things, and afterwards you do the grouping and cross matching. So grouping is already done. Now the cross matching also has to be done with the patient's blood. Donor's blood with recipient serum has to be done. During life-threatening situations, Group O Rh negative blood can be transfused to any group recipient without cross-matching. So there is homologous transfusion. That means you take the blood from the one donor and give it to the recipient. That is the homologous transfusion. Then autologous transfusion. Autologous means the blood of the same person is transfused to that person. So what is this? How can you transfuse the blood of the same person to the same person? Let us see. Elective preoperative autotransfusion. That means now you are planning to do a patient with gastrectomy. So the patient has come to you with a tumor in the stomach. You want to do a radical gastrectomy. His blood hemoglobin, you check it. Hemoglobin is normal and other hematological parameters are within normal limits. So when you want to do surgery, during surgery, the patient will lose a lot of blood and he needs blood transfusion. So the patient says that, no, sir, because of the communicable diseases, I am very much worried and scared, so I don't take blood from anyone. So in that case, what you can do is, you just take the blood from the patient itself, put it in the blood bank, store it at 4 degrees centigrade. Then you give a lot of nutrients to the patient, parenteral nutrients. And after 10 days or 15 days, so because the patient has given around 400 of blood, so his hemoglobin has decreased. So you build up this hemoglobin with good food, nutrition, and nutrients with iron supplements. So after 10 to 15 days, when you check the hemoglobin of the person, that will be normal. So you operate upon the patient, and when needed, his own blood is now used for transfusion. This is called elective preoperative autotransfusion. So in patients with normal PCV and hemoglobin percentage, 1 to 2 units of blood is drawn 3 weeks before any planned surgery and stored. Hematinics and high protein diet is given during this period before surgery. The stored blood is transfused during surgical procedure. Intraoperative autotransfusion. What is intraoperative autotransfusion? Now you have a patient with splenic trauma. Spleen is ruptured. So the blood is bleeding from the spleen into the peritoneal cavity and is being collected there. So you operate upon the patient. So once you open the abdomen, you see a lot of blood in the peritoneal cavity. This blood is not contaminated. It is in a sterile container that is in the abdominal cavity. So if you just put it in the drain, it gets wasted. And because patient has lost blood, he needs blood transfusion. So what you do here is, you open the abdomen and then take out all this blood by sterile technique. Don't use an sterile technique. You take a sterile container, take out the blood and put it in a sterile bottle. So you take a bottle and keep a sterile funnel. So whenever you are doing trauma cases, on the operation table there will be a glass funnel which is sterilized, will be there. So you keep a glass funnel in the bottle and then take out all this blood and put 3 or 4 layers of gauze piece in the funnel, then pour the blood. So all the blood will be poured there. So the bottle will be collected with the blood without any clots. And that bottle also will have the CPD solution, that is anticoagulant solution. This blood is again transferred to the patient. So you can do it like this for 2 cases. That is number 1, trauma to the spleen. Number 2, ruptured ectopic gestation. But of course, before that, you must do the filtration through a gauze piece. So this is called intraoperative autotransfusion. So uncontaminated blood collected in the peritoneal or pleural cavities following trauma, example splenic rupture, ruptured ectopic gestation, is transfused after filtering it through multiple layers of gauze and mixing it with CPD solution. As this blood is deficient in coagulation factors, dilution coagulopathy can occur. So there are 2 types of blood transfusion. One is homologous, from the same species person to same species person after some tests. Then other is the autologous transfusion. Autologous transfusion is 2 types. One is preoperative elective transfusion, other is intraoperative transfusion. That means during operative procedure. Then complications of blood transfusion. So this is very important. Many number of times you find a theory question on this particular topic, complications of transfusion. Allergic reactions, mild febrile reactions, circulatory overload, acute hemolytic reactions, severe febrile reactions, ARDS, massive transfusion complications. So all these things, as an house surgeon, you must identify and manage them. Because when you are giving blood transfusion, house surgeon only will be there in the ward. The assistants or the professors, they will not be available. So you must be able to manage these cases. So you should know thoroughly about these transfusion complications. Allergic reactions. This occurs in about 1 to 3% of blood transfusions. Clinical manifestations, there will be urticaria, pruritus, flushing, or bronchospasm occur between 1 minute to 3 hours time. So that means these reactions, they start as early as possible. So initially there will be urticaria and pruritus. These are 2 common things that are seen. In severe cases, there will be bronchospasm. Commonly seen in patients with previous history of allergic diseases like atopy, asthma, or reaction to previous transfusions. In these patients, washed and reconstituted packed cells will be of use. So there are certain allergic substances in the blood. So they will be causing allergic reaction. So if the patient is repeatedly getting this means, you must give the washed and reconstituted packed cells. Treatment, depending upon the severity of the reactions, the transfusion may or may not be stopped. If there is bronchospasm, means immediately you must stop it. If the urticaria is there, you can just continue. You give antihistamines, then give corticosteroids. Bronchodilators if bronchospasm is present. Then mild febrile reaction. That means the patient will get mild pyrexia. This occurs in about 1% of blood transfusions. It is usually seen after half unit of blood is transfused, or sometimes may be delayed up to 2 hours after transfusion. It may be a warning sign for more severe reactions and hence should be assessed carefully. It is only mild, but if the pyrexia is more, means you have to think of some other serious problem. Treatment, transfusion need not be stopped. You can give antipyretics. In susceptible individuals, it can be prevented by transfusing leukocyte depleted blood. This pyrexia is mostly because of the leukocytes. Because once they are out, they will be some of them will die. So the dead leukocytes, they have these inflammatory mediators and they cause the inflammatory or febrile reaction. Then circulatory overload, transfusion of excess volume of blood. Normal blood volume is only 5 liters. If you give at least a half liter, 1/2 liter more, then that can produce the transfusion overload. Or too rapid transfusion, then the tolerance of the circulatory system. Example, over enthusiastic transfusion, then transfusion in patients with hyperdynamic circulatory states like chronic anemia, cardiopulmonary disease during old age. So in these conditions like chronic anemia and cardiopulmonary disease, if you want to give blood transfusion, and also in old age, you must be continuously monitoring CVP. Then that will prevent the overload. So you must aim only the CVP must be less than 12 millimeters, 12 centimeters of water. Treatment, diuretics, then continuation of blood transfusion at slower speed depending upon the circulatory refilling. The fourth type of complication is the acute hemolytic reactions. This occurs because of mismatched transfusion of ABO incompatible blood or packed cells. So by transfusing mismatched blood cells, that produces the acute hemolytic reaction. Incidence 1 in 6,000 units. Clinical presentation. Whenever there is acute hemolysis, there will be fever with chills, pain, hypotension, nausea, diffuse bleeding, oliguria or anuria, and loin pains. So hemolytic reaction is heralded by fever with chills. So just now we have seen fever. The fever can be due to leukocyte reaction. It can also be due to hemolytic reaction. So if the fever is mild, no problem, but the fever is associated with chills, you must immediately stop the blood transfusion. And you must always call your senior. So if the hemolytic reaction is there, means patients will have also chest pain. There will be associated hypotension, nausea, diffuse bleeding. Still later, there will be anuria or oliguria with both loin pains. That indicates that there is renal problem is there. What renal problem will be there in acute hemolytic reaction? What type of renal problem will be there in case of acute hemolytic reaction? Yes, you are right. It is due to toxic tubular necrosis. The myoglobinemia or hemoglobinemia both can cause this toxic tubular necrosis. If the patient is receiving blood during surgery, that means if he is under anesthesia, so he cannot express the chest pain. He cannot. So you have to monitor, and then you can say whether there is hemolytic reaction or not. So in patients under anesthesia, it manifests as unusual diffuse bleeding from the operating wounds or sudden unexplained fall of blood pressure. So if you are giving blood during surgery and the blood pressure suddenly falls, there is no bleeding. That means the operation is going smoothly, but there is a lot of woozy. So you must immediately think of the hemolytic reaction. These features they manifest during the transfusion of first 30 to 100 ml of blood. And hence, patient receiving the transfusion should be monitored carefully during the first 100 ml of blood transfusion. So any patient who is being given the blood transfusion for the first 100 ml, you should be there in the ward. That means blood transfusion, it will take about 3 to 4 hours to be completed. You cannot give it just within 15 or 20 minutes. All that 500 ml blood, you should not pump. You should give it slowly. So when you are giving it for over the period of 3 to 4 hours time, usually what the house surgeon will do, they start the blood transfusion and they will go and sleep in the duty room or they will go to the canteen. But meanwhile, some complication occurs means the house surgeon will be held responsible. That's why once you start blood transfusion means you must take up the responsibility, and at least for the first 1 hour you should be there in the ward. You need not sit by the side of the patient, but you must be available and you must be monitoring the patient, because the hemolytic reaction occurs during the first 100 ml of blood transfusion. So complication is acute tubular necrosis and disseminated intravascular coagulation. Here when the patient is under anesthesia, it manifests as unusual diffuse bleeding. That's what I said. Why? When there is hemolytic reaction, why should there be bleeding? Why should there be diffuse bleeding? Why should there be diffuse bleeding? When the patient is under anesthesia and blood transfusion is being given, and by any chance if the patient develops acute hemolytic reaction, there will be unexplained diffuse bleeding from the surgical site. I'm asking why such bleeding occurs in hemolytic reaction. In hemolytic reaction, the RBC will be broken down. Why there is bleeding? It is not dilutional coagulopathy. No. Where is the dilution? You are giving just 100 ml of blood and patient started bleeding. One of you said it is consumption coagulopathy. Why it is consumption? Where it got consumed? It is not anesthetic effect. If it is anesthetic effect means every patient must get it, not the only patients with hemolytic reaction. So where the coagulation factors are consumed, Manogya, tell me. Where are they consumed? At the operating part? No. No, not at all. Okay. Whenever there is acute hemolytic reaction, there is free liberation of hemoglobin due to rupture of the RBC. So because of this rupture of RBC, the hemoglobin and other products of the RBC cytoplasm, they will be extruded out. So the free hemoglobin will cause the tubular necrosis. The other products of cytoplasm of the RBC which are released into the circulation will cause the disseminated intravascular coagulation. So because of the disseminated intravascular coagulation, the platelets gets consumed in the process. So there will be thrombocytopenia. Because of the thrombocytopenia, there will be diffuse oozing from the operative wounds. So that is what happens. So there will be diffuse oozing from the operating wounds. Treatment of acute hemolytic reaction. The transfusion should be stopped at once. The donor and recipient's blood is sent for grouping and cross-matching, Coombs test, and hemoglobinemia. Hemoglobinuria confirms the diagnosis. You have to start IV crystallite solutions. That means you must stop blood transfusion and immediately give crystallites. Diuretic after adequate crystallite infusion. Dopamine. Management of DIC by heparin administration and platelet concentrate, fresh frozen plasma administration. So that is the hemolytic reaction. This is given as a hemolytic reaction itself is given as a short notes question many times. And complication of blood transfusion is given very good number of times. I must have seen in the past 10 years at least 3 or 4 times. This question is given. Then severe febrile reactions. Incidence 0.1%. Cause contamination of donor blood or anticoagulants with bacteria or their toxins. Manifestations: pyrexia of more than 39.4 degrees centigrade with chills and rigor, headache, intense thirst and vomiting, hypotension, septic shock. So patients will get the febrile reaction and later he will go into septic shock. Prevention: contaminated blood should not be transfused. How do you know whether blood is contaminated or not? By this observation. The stored blood should be suspected of contamination if it contains lysed RBC as evidenced by pink color supernatant plasma, particulate matter, clots, or altered color of blood. So whenever you are in the house urgency, so you will be asked to get blood from the blood bank and give transfusion. You have to go to the blood bank and then you have to procure blood bottle by yourself and you have to bring by your own hands. The ward boy or sweeper won't go. So when you go to the blood transfusion or blood bank, you the blood transfusion with stored blood. It will taken out from the freezer and will be given to you. Once you look at the bottle, so the bottle will have clear serous plasma. Below that, there will be the RBC, which is red color, and there will be supernatant plasma, which is of straw color. At the interface, you look at it. The interface must be clear. But at the interface, you find pink color plasma, or the whole plasma is of pink color. You must discard it. You should not use that one. That means that already it has lysed RBC. Whenever the RBC are lysed, it leaves hemoglobin pigments stain the plasma there. So the plasma will be red color. So whenever there is pink color supernatant plasma or particulate matter, clots, or color of the blood is altered, you should refuse to take this bag from the blood bank. Blood is normal, but your method of transfusion may be at fault. Special precautions should be taken for preparation of donor skin before withdrawal of blood, as commensal of donor skin may contaminate the blood. So the donors will come and give transfusion of blood in the blood bank. So where the donors, they should come completely after taking a bath. If they do some hard work in the labor, if they work in the hard, do some hard work in the sun, with that sweating skin, they come to the blood bank to donate blood. So there is a lot of sweat which is crusted, which is dried there, which have a lot of microbes. So when you do not sterilize it properly, usually what the people, staff nurse will do to put the needle, they will just take a swab of spirit and then clean it there thoroughly. So they clean it, wipe it, and then put the needle there. The dirt of sweat will not go with spirit. They should use plenty of water with soap, then only it can be washed away. So first of all, the dirt should be washed away. So we must advise the donor to wash his limb thoroughly on running water with soap and water. So if they thoroughly scrub it, all the dirt will go away. Then the sister should clean it with the antiseptic lotion. Then she should put the needle into the vein to draw the blood. Otherwise, all the skin residing organisms, they will also be drawn into the blood and they can cause the septicemia. So blood transfusion is but injecting the bacteria directly into the blood. So that will cause septicemic infections. Treatment: blood transfusion should be stopped immediately. Samples of blood from the donor and recipient are sent for bacteriological study. It is treated as septicemic shock with IV fluids, inotropes, ventilator support, and antibiotics. So it is just like a septicemic shock. It is managed. Then blood transfusion also can cause certain transmission of infections like hepatitis B, hepatitis C, HIV, malaria, in immunocompromised patients, cytomegalovirus infections, Epstein-Barr virus infections. That is why before giving transfusion, you must screen for these 4 organisms. And if the donor is negative, then only you must draw the blood. Otherwise, you should not draw the blood if any of them is positive. Then complications of massive transfusion. Transfusion of more than the quantity of blood volume in 24 hours is called massive transfusion. That means if you give more than 5 liters of blood for a person in a day, then you call it as massive transfusion. The complications can be hypothermia due to transfusion of large quantities of cold stored blood without warming. It causes arrhythmias and cardiac arrest. Then acidosis causes hypoxia of RBC if blood is stored for more than 2 weeks. It causes pyruvate and lactate leak into the plasma, causing the acidic medium in the blood. Massive transfusion of such blood can cause acidosis. Prevention: volume correction with crystalloids and increased tissue perfusion corrects the acidosis. However, some advise 10 ml of sodium bicarbonate after every 3 units of stored blood transfusion. Coagulation defects. Stored blood is devoid of coagulation factors. That means if blood is stored for more than 2-3 days, it will be devoid of coagulation factors and platelets. So prevention is administration of 1 unit of fresh blood or plasma for every 3 units of stored blood transfusion. Hypocalcemia. Citrates in CPD solution can cause decreased levels of ionizable calcium of recipient, presenting as paresthesia and tetany. So if you give large quantities of this CPD solution, there is the anticoagulant solution that is there in the blood bag. prevention is IV administration of injection of calcium gluconate for every 3 units of blood transfusion. However, current recommendations suggest administration of calcium only in symptomatic hypocalcemia. Hyperkalemia, stored blood contains excess of potassium and ammonia, so caution should be exercised while transfusing to patients with liver disease. ARDS, the microaggregates in the stored blood when transfused massively can cause ARDS. Prevention, usage of microfilters in the transfusion tubings. So these are the complications of the blood transfusion. Any doubts regarding blood transfusion? Okay, if I have no more doubts, I will go to the next topic. Okay, if you have no more doubts, we'll go to the next topic. There is fluid electrolyte balance. Okay, there is a doubt from Santi. That is whenever we're giving sodium containing crystalloids in a patient with shock, won't there be any chance of this sodium entering into the cells because the sodium pump is being failed in the cells? Okay, the sodium pump will be failed at a very later stage, not at the early stage. So in majority of the shocks or in the early shocks, there is no sodium pump failure. The patient's cells, only when they become sick or anoxic, this sodium pump failure occurs. So in early stage, there is no such thing. So whenever sodium pump failure is there means, then that leads to the organ failure also. So when we are giving crystallite solutions for every case first, and the amount of sodium what we give will not cause a rise in the sodium in the cells. That is another thing. How much you give in 1 liter of sodium chloride solution? There is only about 350 milliosmoles, 140 milliequivalents of sodium. So we are giving about 140 or 150 milliequivalents of sodium in 1 liter of sodium containing solution. So if you give 1 liter, that means 150 milliequivalents, the whole body cells for the sodium requirement. Even each cell cannot get 0.1 milliequivalent. That means there is not going to cause any addition to already pre-existing sodium in the cells. So in this way, it is not harmful. Okay. Any more doubts, please? The ABG is usually done not in every case of shock. It is not done in every case of shock. ABG is not done as routine. Usually the vital parameters are checked. The ABG is done only in case of the overt compensated and overt decompensated shock. That too not in the early stages. If they are not responding to the fluid therapy, then you go for the ABG estimation and then monitoring of every organ perfusion. But in the initial stages, there is no need for the organ perfusion estimation. So for occult hypoperfusion, there is no need to go for ABC checking, ABG checking. Because they will be normal. It is occult. Even clinically also there are no parameters to say that it is shock. So you cannot expect the ABG to get altered there. So now let us study about the fluid, electrolyte and acid-base balance. Body fluids. Life of cells depends on supply of the water, oxygen and nutrients to the tissues and cells. These are supplied through the body fluids. So of course they are transported through the blood, but they are ultimately supplied through the body fluids. So the body fluids are necessary or essential. So the distribution of body fluids yesterday I told you. That is why I will go very quickly through these slides. 50 to 60% of body weight is about 40 failures. About 40 failures I just said. So it is anything between 40 to 50 liters. That is the normal weight of water in the body. It is distributed in the cells, outside the cells. In the cells, it is about 30 liters. Outside cells, it is 15 liters. The extracellular is again divided into two parts, the interstitial and intravascular, in the ratio of 11.5 and 3.5. That means the ratio is 9:3:1 between the intracellular, extracellular, and intravascular. The intravascular is having the semi-permeable membrane, that is the capillary. Through the capillaries, the crystallites and water can be transported either way. Colloids are not being transported across the capillary membrane. For the third space, this is not necessary. The transport of fluid. Fluid passes across the compartments depending upon the following factors: osmotic pressure, the electrolytes, the proteins and solutes, they follow the osmotic pressure. Then hydrostatic pressure, which is dependent upon the cardiac output. Then cell membrane integrity, that is sodium, potassium, ATPase. So osmotic effect I told you already. So cell integrity also I told you. So if some quantity of fluid is administered to the intravascular compartment, how it gets distributed, already I told you. If it is a plain solution, that is electrolyte free solution, it is distributed equally among all the three compartments in the ratio of 9:3:1, because that is the ratio of these compartments. If sodium containing fluid is administered, it is being distributed only among the interstitial space and intravascular space. If only colloids are being administered, they are confined only to the intravascular space. So this is about giving, I said. If there is loss is there, For example, a sodium-free solution, that means plain water, is lost from the body. For example, excessive diuresis is there. Our patient is not taking water at all. There is water depletion. So in water depletion also, there will be less of water in the body. So whenever there is less of water in the body, how the intravascular space is being affected? In the same way, 9:3:1 ratio. That means if the patient has lost 13 liters of water outside, means there will be 1 liter loss in the vascular space if it is plain water. If it is sodium content solution is being lost, that means in the form of vomitings or diarrhea. So then where there will be, this loss will be distributed among the interstitial space and intravascular space. If the patient has lost plasma, example is burns, so the whole loss will be experienced in the intravascular space. I hope you got my point. So pattern of distribution of fluid deficit. If 13 ml of fluid is lost, if sodium-free solution is lost, so the loss will be 9 ml in IC space, 3 ml in interstitial space, 1 ml loss will be there in intravascular space. So there will be more of cellular dehydration. If solution is lost, it is distributed, the loss is distributed among these two compartments in the ratio of 3:1. How this fluid balance is being controlled in the body normally? They are controlled mainly by the kidneys, adrenal cortex, and by posterior pituitary. So that is basic physiology regarding fluid electrolyte balance. With this, now we'll go to the description of electrolytes. The electrolytes in the body fluids exist as ions, that is, as cations and anions. That means if you take a jar and put some saline solution in that, now for example, this is a container. You take some solution here. There is a salt solution. You keep 2 electrodes. You connect it to a cell. You connect it to a cell. What will happen then? This electrolyte solution will now dissociate. Some ions, of course, this is the positive, that means this is anode, and this is negative, this is a cathode. So some ions will travel to the cathode, and some ions, they will travel to the anode. Those ions which go to the anode are called the anions. Those ions which travels towards the cathode, they are called the cations. In a solution, the total number of cations and total number of anions are equal. Sodium chloride solution. Normal saline, that means 0.9% sodium chloride solution. That means it contains, in a 1 liter of water, it contains 155 milliequivalents of sodium and 155 milliequivalents of chloride. Equal, same quantity will be there. So one is the anion, other is the cation. Sodium is the cation, chloride is the anion. So this is the distribution of electrolytes in the body fluids. In the plasma, in the interstitial fluid, and intracellular fluid. if you look at the plasma and interstitial fluid, almost they are alike. There is not much difference between them. So you can see in the plasma, the chloride is 103, here it is 114. Sodium here is 142, here is 144. Potassium is 4, then the calcium is 5, the magnesium is 3. So almost they are similar. But here the anions are also similar in the interstitial fluid. That means they are almost in equilibrium. Only difference is plasma has protein and interstitial fluid has no protein, or just marginal amounts of protein is there. But the electrolytes, the anions and cations, they are all almost equal. But in the cells, it is totally different. Potassium is 150, but in the cells, it is 140. So potassium is only 4, but in the cells, potassium is 150 and the sodium is just 10 milliequivalents. The magnesium is 40. So total there will be 200 milliequivalents of cations here. Here there is only 154 milliequivalents of cations in plasma, but here it is 200 milliequivalents. The anions are also 200 milliequivalents. So they are phosphates and sulfates. They constitute the major quantity. Then bicarbonates, they will be around 20. Then proteins, they are about 40. So this is the intracellular concentration. The important cations being the sodium and potassium. We're not going to study about the magnesium and calcium because they are a very small quantity and they are not going to cause much changes. That's why we concentrate upon the two electrolytes, sodium and potassium, and their disturbances. We will study them. So the important anions are the anions being the anion side, this is the chlorides and bicarbonates are the important anions. Sodium, it is a major extracellular cation we have seen just now, both in the extracellular space as well as in the plasma. Sodium is the major cation. It is around 140 milliequivalents per liter and is responsible for extracellular osmotic pressure, maintaining the extracellular volume. So extracellular osmotic pressure is being maintained because of the presence of sodium. So if sodium is more, it draws water. If sodium is less, it leaves the water. So sodium automatically, because of its osmotic action, it keeps the water with itself. The sodium is controlled by mineralocorticoids and ADH hormone. Then potassium, it is responsible for cellular integrity and cardiac and neuromuscular function. So potassium has mainly the intracellular action. But sodium, because of its large quantity, it exerts osmotic action, so it exerts influence on the water. But potassium is not like that. Potassium is a major constant of the cells, so it has its action on the cells. So that is why it is mainly responsible for cellular integrity and as well as for cardiac and neuromuscular function. Thus, even minor changes can have major effects on the cardiac activity. The intracellular and extracellular distribution of potassium is influenced by a number of factors. So we have seen intracellular 140 milliequivalents of or 150 milliequivalents of potassium, but outside there is only 4 or 5 milliequivalents of potassium. So how this is being maintained? Because of the sodium pump. And this gets influenced by various factors like surgical stress, injury, acidosis, and tissue catabolism. So all these factors influence the distribution of potassium within the cells and outside the cells. Insulin promotes entry of potassium from outside the interest, that means outside the cell into the cells. So you can see again the table. Sodium extracellular 142, intracellular only 10 milliequivalents. Potassium outside is 4, inside is 140. Chlorides is 110, inside is only 3. So instead of chlorides, here there are the organic acids and the glucose. That means phosphates and sulfates are there. The bicarbonates in this cell is only 10 milliequivalents, but outside is about 25 milliequivalents per liter. So total osmotic tension of all these things put together, it is about 300. That means 275 to 300. Normal daily balance of water and minerals. Normally we consume water during food intake. It will be around 1000 to 1500 ml. In the solid food of food, we have about 1000 ml of water. Due to body metabolism, normally we secrete about 300 to 500 ml of water. That means normally there will be around 2 to 3 liters of water that is taken inside in various forms. Then output is urine is around 1500 ml. It varies in input. That means if person has taken more amount of water means he will pass more urine out. Then insensible loss from skin and lungs, it is around 1000 to 1500 ml. In the form of feces is around 100 ml. The total amount is about 2.5 to 3 liters. That means the input is balanced against the output. If input increases, the output increases in the form of urine. If the input decreases, the output decreases in the form of urine. But the other things, the two things being maintained constant. So the other two sources of loss being insensible loss from skin and lungs, then through the feces. The daily requirement of electrolytes being sodium 150 milliequivalents per day, that means 6 grams per day. Potassium 40 to 60 milliequivalents per day. Chlorides 190 milliequivalents per day. So these are the daily requirements. If by any chance if you have taken more of them, then there is no problem. The kidneys are there, they will take care of that. Under the influence of the hormones, which are very sensitive for the sodium and potassium levels, they will be influencing the kidney to excrete excess of sodium or potassium from the body. So our body gets rid of all this potassium and sodium whenever they are being in excess. The types of IV fluids normally we administer. So this is the plasma concentration of electrolytes. You must remember these things. Sodium 140. That means you can say average plus or minus 5. Potassium, it is 4. That's 4 to 5.5. Chlorides 95 to 105. Bicarbonate 22 to 25. So these are the normal values. You must by heart these 4 values. Very, 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 very important. Even in the deep sleep, if you are asked to tell about what is the normal potassium level in the serum, you must be able to answer it. Okay? Now the fluids that are commonly employed. Normal saline. You are hearing this word normal saline, NS. That is 0.9% sodium chloride solution. 0.9% sodium chloride solution. Why 0.9% is chosen? Why not 1%? Instead of 1%, why you are taking only 0.9% sodium chloride solution? Is there any reason? Equal to plasma means equal to what? Plasma means what? Okay, you said near to plasma. That is all right. What is equal to plasma? Okay, sodium and chloride levels. Okay. sodium and chloride levels, they are little less in the plasma, isn't it? You can see just on the yellow border, you can see chloride is only 100, but you are giving 153. So how it is equal? This normal saline is made not taking into the account of sodium and chloride levels in the plasma. It is manufactured keeping in view about the osmotic pressure of the plasma. The osmotic pressure of plasma is around 300 milliosmoles. You must give any fluid into the blood circulation which is osmotically equal to the plasma. If you give a hyperosmolar solution, instead of 300, which is the normal of the plasma, you give 400 milliosmoles. What will happen? There will be osmotic disturbance. So the water from the RBC will be shifted into the plasma if you give hyperosmolar solution. So there will be shift of water that causes crenation of the RBC. Similarly, if you give a low osmotic tension fluid into the plasma, then water will shift from the plasma into the RBC, causing swelling of the RBC. That is why you should never give osmotically different solutions to the plasma. Any solution which you give into the or administer into the plasma should always be isotonic with plasma. That is 300 milliosmoles. So 300 milliosmoles of sodium containing solution means it comes to 0.9% sodium chloride solution, because 0.9% sodium chloride solution has milliosmol capacities of about 280. So that is why it is taken as a standard. This is called normal saline. Normal means just like that of the plasma. That is why it's called as the normal. Like that, the plasma means not as the quantity of the sodium and chloride. About the, it is osmotic tension. Osmotic tension is same as that of the plasma. So that is normal saline. So that 0.9% non-sodium chloride solution, so-called normal saline, contains 153 milligrams of sodium and 153 milligrams of chloride. Little higher sodium and very high chloride. That means if you administer sodium chloride, what you are going to do? You are going to add more of chloride to the patient than required. Because plasma is having only 100, but you are giving 153. So if you give 2 liters of sodium chloride solution, means you are going to give at least 100 milliequivalents of chloride more to the body. So when more of chlorides are given, what will happen? If more of fluorides are given, what will happen? Anion gap. There will be acidosis. Of course, I know about anion gap. Yes, it is acidosis due to anion gap phenomena. Okay. So this is normal saline. Then Ringer's lactate solution. It contains 130 milliequivalents of sodium, 4 milliequivalents of potassium, 110 milliequivalents of chlorides, and 28 milliequivalents of bicarbonate in form of lactate. Then Darrow solution, 124 sodium, 36 potassium, 104 chloride, and 56 bicarbonate. That means it contains a lot of potassium. So whenever you want to replace potassium, you give Darrow solution. 5% dextrose. It is a dextrose in plain water. Why 5% dextrose? Because it is osmotically equivalent to the plasma. So all these solutions, they are osmotically same as that of the plasma. 5% dextrose has no electrolyte. So whenever you want to give electrolyte-free solution to a person, you administer 5% dextrose. So these are the 4 commonly employed. This ringer lactate is having the same composition as that of the plasma. Osmotic retention also is same as that of the plasma. That is why whenever you want to give a crystallized solution, you prefer to give Ringer's lactate solution. Whenever you want to give a potassium containing solution, you give Darrow's solution. Whenever you wish to administer non-crystallized solution, you give 5% dextrose. You should not give plain water. Plain water has osmotic retention of 0. So if you give plain water, they will cause hemolysis of the blood cells. So you should not give plain water. You must give only 5% dextrose. Whenever you want to give plain water means instead of plain water, you give 5% dextrose. So these are the commonly administered types of the fluids. So we'll stop it here, and tomorrow we'll study the remaining part of the fluid electrolyte and acid-base balance, as well as the metabolic response to trauma and surgical nutrition. So these topics we will cover tomorrow. Any doubts? Okay. If you have no more doubts, I will close this session. Okay, thank you. Okay, Santi, I will explain tomorrow again about mixed venous saturation, no problem. Okay, thank you. See you tomorrow. Wish you all good night. Bye. Thank you.